Well, hello everyone. Jenny Fennell here, CRNA, and your host of CRNA School Prep Academy podcast. Welcome back to another episode this week. So today we are going to talk about induction of anesthesia. And so if you are currently practicing as an SRNA, this may pique your interest. If you're thinking about becoming a CRNA, you may be interested to kind of see what are some of the things that go into an induction of anesthesia. And if you're a current student, you may have actually heard that induction is kind of like taking off if you're in an airplane. And so some of the most critical parts of a case can be the induction and emergence, because that's for the anesthesia side of things. That's when a lot of things can go wrong in anesthesia. Usually once you're in the maintenance phase, you've kind of smoothed things over. It's kind of like being up in the air in an airplane. So that's kind of how I think of it anyways. But let's go ahead and start from the top. So essentially, when you plan your induction, your anesthetic induction, there are some things you really need to initially start thinking about and come up with a game plan on what you're going to do. And number one, and first and foremost, is your patient and their history. So that's one of the first things you're going to dive into, is really getting to know your patient and some potential areas of concern, like are they at risk for aspiration? So do they need a rapid sequence? Do they have maybe a low ejection fraction of their heart? So maybe we have to do a gentle induction. It's like I said, I had a patient that actually had a VSD. And again, I made sure I looked up the echo report to see whether this VSD had gone away, and it had. And so some VSDs, which is usually a left to right shunt, goes away by age 2 or maybe even 4 years of age. And then if it doesn't, then you can always do some interventions. But knowing the left to right shunt is not as dangerous as a right to left shunt, because a left to right is where you're remixing oxygenated blood with deoxygenated blood, versus a right to left shunt, which is unoxygenated blood going straight into the body and the system, usually causes more problems with hypoxia and things like that. But we're not going to get into that today, but I'm just letting you know, those are some of the things where you want to be investigating and knowing more thoroughly. Like, for example, if your patient has a history of GERD, you have to make sure you're asking, do they currently have any symptoms of GERD? How well controlled is it? Same with like asthma. Okay, they're asthmatic. Some people list asthma in their history, but they maybe only take an inhaler as needed, versus an asthmatic who takes it around the clock every day. So again, you need to know these things. Knowing things like whether they've had a recent respiratory cold can really, in your mind, say, okay, well, this person's at higher risk for, say, a bronchospasm during induction. So what can I do to prevent that from happening, to decrease the risk of that actually happening? So that's what I mean. You really need to dig into the patient's history to actually come up with a game plan for your induction of anesthesia. So that's kind of the first thing you want to be aware of. Next is, and probably kind of goes hand in hand with number one, is what case are you doing? Okay. Depending on the type of case you're doing, it's really going to change and tailor the type of anesthetic induction you're going to do. Okay. Starting an induction for an open heart is very different than, say, starting an induction for, say, an AV fistula. Okay. They both have considerations to take into hand. One would be a general anesthetic with endotracheal tube. Now, if you're doing, say, maybe a mini AVR open heart case, you'll be doing one lung ventilation potentially. So therefore you'd have to plan for that. Where if you're doing a case for an AV fistula, those are typically done under MAC, okay, which is a monitored anesthesia care type of case. And so that's what I mean. The induction of anesthesia looks very different for those two cases. And so knowing your case and what to kind of expect from the case plays a vital role in how to prepare for your induction of anesthesia. And if you're a current student, you probably know the word Jaffe. In fact, it probably hunts you in your dreams, as it did mine as a student. It's a very, very thick book of surgical procedures, and it kind of gives you an anesthetic viewpoint on how to manage those, the anesthetic through those particular types of procedures. For example, an awake cranie is a very different anesthetic than, let's say, a trigger finger. Okay. So every anesthetic can be tailored uniquely to the patient's needs. So that's also, I get people who say, is anesthesia boring? I don't think that that's boring. In fact, that's very mentally stimulating to always be on your toes and think, well, how can I tailor this anesthetic to this particular patient and to the particular case? Because not only are you taking into consideration the case, but you're also taking into consideration the patient's unique maybe mental, but physical health. You're taking their physical health into consideration as well. And so no two lap appies, for example, are going to look the same because the patient is different, which I think is one of the fun things about anesthesia, is the fact that you really get to truly tailor every individual anesthetic you deliver to the actual patient's needs. And so that's the second thing to kind of consider is what kind of case you're doing will really change and shift your type of induction. And then obviously based on the type of case leads you to, well, am I doing a general or am I doing a MAC kind of case? Some people call MACs Twilight anesthesia. And what I can say is generals, you can have a secured airway or a non-secured airway. In fact, a lot of monitored anesthesia care cases or Twilight anesthesia cases truly are generals. Because if you look at the definition of a general anesthetic, it's loss of consciousness and not being able to respond to stimuli. And I can tell you from working at a surgical center who did a lot of MACs or Twilight anesthesia cases that they were really truly generals without an airway. And so I really encourage you to kind of first recognize that. And, you know, with every type of anesthetic you do, you really always want to be thinking of a plan A, plan B, and plan C. And maybe even further than that, you want to always be thinking, well, if this doesn't go right, or if I need to intervene because this is not going to work, what would I do next? And if this patient has this in their history that may cause this potential complication, then what can I do to preemptively either A, prevent it? That's always the best outcome, is preventing something from happening. That's always how you should be trying to think, is how can I prevent this? You don't really want to be dealing with something after it happens. However, you still have to think, well, if this does happen, what would I do? Okay, so I encourage you to always take that approach when you're assessing every single anesthetic you do. And I promise you that if you can do this routinely, you are going to be able to react quickly and be really prepared for anything that can fall onto your plate during the anesthesia and wake up, emergence, all of that. But I'm going to ask you, and if you're an SRNA and you're listening to this, do you know the difference between an induction, a general induction, and a Twilight induction? I guess my question is, how do you know someone is, how do you know you're through the induction phase when you're doing a Twilight? If anyone, think about that a little bit. And I'll kind of give you my personal opinion on that. And again, this is from me doing a lot of those types of cases. And what I can say at a general anesthesia, it's a very much more clear picture of when you've completed induction versus a Twilight. Twilight can be a little gray, and we'll get into that here in a little bit. But, you know, general induction typically starts off with, if you're working with peds, it's usually an inhalation induction followed by an IV, and then you give IV adjuncts to kind of aid in your induction. That could be fentanyl, rocuronium, and maybe a little bit of propofol or whatever they need via the IV, Zofran, Decadron, that kind of thing. But you actually start your anesthetic with like sevoflurane, for example, which is an inhalation agent that causes amnesia. Okay, so that's typically how you start those cases. So that's one type of general induction style. Then you have a general, typical adult style general induction that can be with an endotracheal tube or with an LMA. And that is where you just give them oxygen to breathe, to pre-oxygenate them. You don't typically give anesthetic gases at that time because it stinks. The only thing that doesn't stink is nitrous. But, you know, typically in adults, since they have an IV, you don't have to bother with nitrous. You go straight to 100% O2 because you have the IV, and you want to really make sure you're tanking up their FRC, which is the functional residual capacity, which is the space in your lungs that you can actually fill with 100% O2 that will actually buy you time for apnea. And it doesn't mean that it's going to control your ventilation. Remember, ventilation is about CO2. This is going to control desaturation or hypoxemia. So it'll buy you more time to not desaturate as quickly. And in your time as an SRNA, you're going to see someone who maybe has a big barrel chest or has a lot of weight up top. Maybe they're apple shaped of some kind. They're going to desaturate much more quickly than someone who's pear shaped because they're going to have a lower FRC, and you're not going to be able to pre-oxygenate them as well as someone who, say, is pear shaped. A way to overcome this, if this is your situation and you want to impress your preceptors, is get a ramp. Just a little bit of a ramp can go a long way to kind of decrease the pressure on someone's chest. You can also sit the head of the bed up a little bit too. So keep that in mind when you're planning your pre-oxygenation ritual. Also making sure you have a good seal. That's probably one of the most common mistakes people make when they pre-oxygenate is they do not have a good seal. And when you break that seal, you're losing all that pre-oxygenation. You really need a good seal when you're pre-oxygenating. Ideally, you want to see your end tidal CO2 be above 85%. Okay. If you can get your end tidal O2 above 85%. I'm sorry, I said CO2. You definitely don't want your CO2 above 85%. So if you want your end tidal oxygen to be reading 85%, that's when you truly have known you've done a good pre-oxygenation for your patient. But anyhow, so kind of back to a general versus a MAC induction. Again, with a general induction, you're pushing IV drugs. And then essentially kind of how you know you've kind of surpassed the realm of consciousness is, one thing that you'll see routinely done is you check for eyelash twitches. So if you kind of graze someone's eyelashes with your finger, you'll see their eye twitch. That's a signal that they're not completely induced yet. Okay. That's kind of like, okay, they need more time. And what's kind of fun, I think, about IV induction is you get to see their circulation time. Does anyone know what circulation time is? So circulation time is the time it takes for your body to pretty much circulate your blood in your body. And that correlates with how quickly your blood from where you're injecting the anesthetic reaches your brain to actually cause the amnesia, analgesia type effects, okay? And so someone who has a low ejection fraction, say 10, 15%, is going to take several minutes to truly have an IV induction. So where you can run into problems where, like, if you're not losing if you still have an eyelid twitch, and so you're like, oh, they need more, and you keep giving more propofol. Well, then you could actually really, really hurt the patient because now you've overdone it. You didn't give yourself enough time to truly let those meds kick in and do their work. You would be surprised at how little it takes to truly do a true induction to knock out someone's recall. It does not take much, okay? And again, you have to take their age in consideration and that type of thing as well. But I'm just letting you know, if you're not patient with your induction, IV induction, you could actually overdo it and give them too much propofol. And then you're dealing with hypotension. It's not really a fun way to start a case ever. And it's not good for the patient. So make sure you're being patient with someone who maybe has a slower ejection fraction and giving the IV drugs time to actually get to the brain. Okay. But what you'll notice is, like, say you do an induction in a healthy teenager who's like really nervous and they're tacking away at a heart rate of 130 and they're just like all ramped up. They're going to go to sleep much quicker because they're going to have good circulation time. Okay. Most of the time, you can always play a game with them. It's like, let's count back from 10 and see how far you make it. Usually it's within 10 seconds, they're already asleep. Give or take. Sometimes they reach 13 or 14, but usually for sure within 15 seconds, most even young, healthy kids are asleep. And that is, so when you're kind of in this weird phase where you maybe are a little more sedated, but not quite under general anesthesia, meaning your induction is not 100% there yet, you can turn on your anesthetic gas to kind of help, and not a lot. I mean, like, 0.3% end tidal of your gas to kind of help knock out the recall a little bit quicker and kind of make everything work together. What's kind of nice when you do that technique, you're not slamming tons of propofol. If you give just what you think you need of the propofol and turn on just a smidge of gas along with some fentanyl, you're going to have the amnesia, and that induction is going to be sped up by incorporating the anesthetic gas as well. And so I would typically do that. So after, the patient's getting pretty sleepy, even if they haven't quite lost their lid yet, but I can tell they're not as responsive to being talked to, I would turn on some gas. I would start helping them, just give them a little tiny gentle breaths. You don't want to cram in giant breaths or anything like that, but just let them breathe with you. Don't overdrive them or anything like that. Let them breathe until the anesthetic truly has caused its induction. And then when they actually stop breathing, that's when you take them over. And don't be afraid if you need to do a good jaw thrust, oral airway, make sure you always have that set out. And I didn't cover that, but when you prepare for an induction, you have to make sure you have all your emergency supplies ready to go. And that can be drugs, airways, all those types of things. You want to make sure, again, you have a plan A, B, and C. And so if you're anticipating potentially a glide, because based on your patient history and assessment, you anticipate an anterior airway, you need to make sure you at least have the glide in the room. Maybe you're like, well, let's go ahead and see what we see with the DL so we can document what we see. But I have the glide there and I have an oral airway on standby so that way I can make sure I can at least mass ventilate. Because as long as you can mass ventilate, you guys, you have an airway. It's cool. Take your time. No need to panic. No need to worry. If you can mass ventilate, you're going to be okay. The patient's going to be okay. Take your time. There's nothing worth you don't need to rush and, potentially damage the patient's teeth, or gosh forbid you damage something on their airway and cause bleeding because you're rushing. Because as long as you can mask ventilate, you're going to be able to take your time and tank them back up. Meaning, let's just say you start an induction, you take a look with your DL and you don't see anything. Maybe you didn't anticipate that. And now you're starting to panic. You're like, oh no, I don't see any airway. They're desatting on me. Oh, I got to try to get this tube in. And you getting flustered and panicking. First, take a deep breath. It's okay. Could you mask them? That's what you need to start thinking. Can I mask them? Okay, come out, mask them, do an oral airway, whatever you need to do. If you need a 2-hand mask, do a 2-hand mask, whatever you need to do to mask the patient. And remember, an LMA is a great thing to have on your back stand in case you can't easily mask ventilate. Sorry, I'm fighting a cold, or I was fighting a cold. So see, I'd be high risk for bronchospasm. So sorry, I was hoping not to have to do that. So yeah, I just got over a respiratory cold, high risk for bronchospasm right here. Please take precautions. Okay, so anyhow, emergency drugs like that would include things like succinylcholine, in case you get a really bad laryngospasm. That would include things like atropine in case you get some severe bradycardia. And even in kids, I always have some Robenol there, because a lot of times when you're doing this inhalation inductions, you can actually go into junctional rhythms. You can slow down really much. And in the pediatric case, bradycardia is severe. You know, they're really dependent on their heart rate for their cardiac output. So Robenol is also on our emergency backstand in kids. I wouldn't say in adults we routinely did that, but for kids we do. And so something to think about as well. But yeah, have your backup meds, have your backup airways, nasal trumpet, even an oral airway, whatever you think you need, just have it within reach. Doesn't mean you have to like crack it open and have it ready styleted, but make sure you have it within reach so you can easily grab it. Okay. The last thing you want to be doing is ever turning your back to the patient. Gosh forbid, don't ever do that. But you don't want to have to be turning, and you want to be able to have your hands, you want things close by so you can easily grab it and get it ready to go. Okay. But back to my question, as far as telling the difference between, say, a general induction or a MAC or a Twilight induction. As I said, for a general, you really look for that loss of lid reflux where you're actually twitching. And actually to kind of spoil some big suspenseful thing here, it's very similar for a MAC case as well. However, if you're truly doing a MAC, you guys, you should always be able to be responsive, meaning a true Twilight case, the patient with noxious stimuli, you know, could potentially respond and answer your questions, or at least be, you know, cognizant. Like maybe they don't remember, but it's kind of like being drunk, essentially. It's probably, I don't know if that's the best, but I think it's kind of a good comparison. You know, like you'd be drunk and completely blacked out and not remember what you're doing, but yet you're alive and you're doing these things that you won't remember doing the next day that you'll regret. It's kind of like that, where you're going to have amnesia, but you're still going to be kind of awake and be able to, if you really needed to, you're going to say, ow, okay, that was too painful. That hurt. You know what I mean? So that's like what a difference is between a Twilight and a general anesthesia. General anesthesia, you will not get that. And now it doesn't mean the patient won't move, because they will. You have to have, what is it, like a MAC of anesthesia, only 50% of the patients won't actually move to noxious stimuli. So keep that in mind. Even if you have a solid MAC on and you have amnesia, the patient, if they get stabbed with a knife, they're still going to be like, ow, their body's going to reflectively pull away. In the Twilight case, you know, again, the patient is not going to have an endotracheal tube down their throat or an LMA in their throat. So they're going to actually be able to vocalize, hey, I don't like that. Or, you know, they're going to be able to tell you. What I can say is that the vast majority of time that you do a Twilight anesthesia, what the surgeon likes usually, and what, you know, probably most anesthesia providers prefer, is to have a really heavy MAC, meaning they're not going to move on you. They're not going to respond to noxious stimuli. So it's technically kind of like a general without an airway. So you have to be really careful with this. Don't get me wrong. It's done all day, every day, and it's safe, and it's needed. It's necessary. It's good for the patient. You just have to make sure that you're on your A game, because now, I mean, in my opinion, it can potentially be a riskier type of anesthetic, especially, here's the key, especially with the wrong patient in the wrong case. Okay. There are limitations to a Twilight anesthetic, and there are limitations to who you can do this on. You can't take someone with Pickwickian syndrome, when you guys Google that, or, I mean, let's just say they have severe sleep apnea and, you know, a BMI of 60, and, you know, you're like, I mean, there's just a little bit of fentanyl is going to make them obstruct. Okay. You need to be very aware of what you're working with here to know that you can to deliver a safe, heavy MAC. So make sure you're keeping that in mind. And also another thing to keep in mind too, is making sure, depending on the case, that you're not overdoing it. Okay. For example, I have to give examples so you understand. You could be putting, say, a carotid stent in. Do you think you want a carotid stent patient to be completely out to where they can't vocalize or tell you anything during the case? What happens if they stroke? Okay, so If you do that, your surgeon's going to be so mad at you because now you have put the patient at undue risk. Okay. That's what I mean. You have to really think about, well, what is the case? You know, and the thing is about those types of cases where you have to keep them a little more awake, and yeah, they could have recall. The thing is, you cannot promise a patient undergoing Twilight anesthesia or MAC anesthesia that they will not have recall, because the risk is always there. And one of the best ways when I was in school that they kind of described how to keep a steady state under a Twilight anesthesia is, think about, you know, when you have an infusion going, you're delivering a steady state of drug. That's the best way to create an even plane of anesthesia. However, based on the stimulation going on in the case, your needs are going to change, right? So, you know, if the case all of a sudden becomes more painful versus not painful, you're gonna react. If that steady state of plane kept you comfortable during, say, you know, the first half of the case, the second half of the case, maybe it's a little more invasive and maybe they didn't numb as good. A lot of Twilight cases go hand in hand with good localization from the surgeon, and sometimes it's better than others. And so, you know, maybe they're coasting along, they're doing great, and you think they're deep enough, and next thing you know, they're like, ow, I felt that. And you're like, oh, okay, well, you know, first couple things, as an anesthesia provider, you're going to get the stares from the surgeon who's going to be like, make them comatose, but you can't do that and be safe. You have to say, can you please give more local? I will do my best that I can from my standpoint, because again, it's supposed to be a MAC. You don't have endotracheal tubes. You're not taking over their respirations. They have to breathe. So you have to be really aware of how deep you can get them. That's on the borderline of still being safe. Okay. So a MAC, you guys, actually is a really tricky case to do versus a general anesthetic. It's kind of easy when their ventilation's controlled and their anesthetic's more controllable, and you don't have to worry about, you just paralyze them. It's actually easier than having someone who you can't paralyze and who you have to keep breathing. So something also to keep in mind. Okay, sorry. A little bit more difficult to record this podcast episode than I thought, recovering from this cold. Anyhow, so again, the Twilight, again, can be kind of a trickier type of case to do, but really kind of how I would judge whether I've really truly finished my induction is, well, typically the way those cases tend to work is you get them in the room, you start working in some drugs, whether that's fentanyl or Versed. You know, you can do a ketofol. There's the different ways too. You can do your Twilight anesthesia. Ketofol is where you mix propofol with ketamine. You know, if you're worried about giving fentanyl, for example, because maybe they're high risk of being sensitive to their CO2, maybe they're already have sleep apnea, ketamine's a great drug of choice because you don't get the respiratory depression with it like you do fentanyl. So again, kind of tailoring your anesthetic to the patient's needs, back to that again, which you will always continuously do. And you can even, sometimes you start a case and you think you've done a tailored anesthetic, and then you have to go to your plan B because now something else has happened. But either way, again, you want to make sure that you're giving them kind of a nice little cocktail. What I like to do too is I would give a little bit of fentanyl Versed if necessary. And then I would immediately put my lidocaine in, and then I would kind of slow down I would turn my IV off and let that lidocaine kind of soak in the vein and kind of create like a little, you know, mini little beer block or whatnot. And that way, when I started my propofol infusion, the vein was nice and numb, because propofol can burn. You will see that when you push propofol, if you haven't used lidocaine, and sometimes lidocaine, you know, if you're pushing lidocaine fast and it's going right through the vein, it may or may not work that well. It still has sedative properties, and it, you know, kind of creates kind of, it still works as a good adjunct to your anesthetic. But as far as preventing the burning sensation from the propofol, it does tend to work best the longer you kind of let that soak in the vein. I've seen providers mix it. You know, so again, do what you think is best, maybe play with different variations of this to see what you find works best. I encourage that, especially as a student. But anyhow, so you let that lidocaine soak, and then you hook up the propofol infusion as you're getting them on the monitors and everything else, and finishing getting their oxygen on, and kind of talking to them, let them know what to expect, making sure they're comfortable. Make sure you always do that. You never want someone to go to sleep when their neck hurts and then have them wake up with a bad neck pain because you didn't make sure they were comfortable in the current position they're at. So never forget the positioning of the patient. That's your job, your responsibility, to make sure they're positioned so they're not going to get an injury. And then obviously, and then essentially I would always bolus the propofol. Okay. And now how much you have to bolus, that's where your tailored approach comes into play, and to kind of understand their history, what the anesthetic needs are, how painful is the stimuli going to be, when is the surgeon in the room, when is the surgeon going to be ready to actually cause more stimulation. Because if you slam them with propofol and the surgeon's not even in the room yet, well, you're going to have a period of apnea that you better be prepared that if they don't come back breathing on their own, you better be prepared to slam that mask on and help them breathe until they can come back breathing. Propofol is very forgiving. You will get them back breathing pretty quickly with just propofol, but depending on how well they've been pre-oxygenated, depending on their FRC, depending on their age, overall health, yada, yada, you're going to see a variation in desaturation. Okay. So obviously you don't want that to progress to anything that could be life-threatening. You know, most kids don't tolerate hypoxia. You know, a healthy adult may tolerate a little bit more, but hypoxia can cause bradycardia. And again, like I said, bradycardia in kids can cause, you know, a kid to lose perfusion and circulation. So again, know your patient population you're working with and what you can get away with. Okay. So essentially when I know I've done a true induction with a Twilight anesthetic, you know, if I say their name, call their name, they're not going to respond to me. That's kind of how I know. Then the next test I do is I maybe give a little bit of a painful jaw thrust. If you touch right behind your jaw, go ahead and do it with me. Touch it right here and push. You'll see your jaw move out and it doesn't feel that great. You can always test that, see if they start moving. If they start moving with that, then you're like, okay, they're deep, but they're not maybe quite deep enough, you know, for stimulation, for a real painful stimulation. So you can always give them a little bit more when you know the surgeon's getting ready to cause more pain. And then what you do is pretty much once they're localized and through that painful part, because the localization hurts, then you kind of just let them coast. You can lighten them back up a little bit. Again, make sure they're breathing and exchanging well. You want to be monitoring their end tidal CO2. If they need an oral airway, give them an oral airway. If they need a nasal trumpet, give them a nasal trumpet. Just be careful. I would probably use some Afran preemptively, or you could even spray a little bit of the end of it with some Afran and lidocaine jelly and just stick it down their nose. Because you can cause a significant nosebleed with a nasal trumpet. So just be very, very gentle. Make sure you're picking the right size. The worst thing you do is pick the wrong size and have to put another one in. And trust me, if the patient's too light for a nasal trumpet, they're going to let you know, because it's not fun to have something stuck down your nose in the back of your throat. But that being said, it's easier to stick a nasal trumpet in someone who is on the borderline of being awake than cramming an oral airway in. Because if you still have that gag reflex, that oral airway can really gag you and just make the patient cough and cough and cough. And so you have to be very, very deep for an oral airway to go in under a MAC anesthetic, just putting it out there. So I think that kind of covers the vast majority of induction types and styles and maybe things to think about. I hope that it wasn't too overwhelming for you guys, because it is a lot of fun. I think it's fascinating that it really keeps you on your toes. And the fact that we get to tailor it to your unique patient, your unique case, I think it's fun. You're going to have fun doing it. So I hope you guys enjoyed today's episode. Tune in next week. Make sure you go ahead and follow me, like me, thumbs up me, all of that good stuff. I appreciate you. And we'll see you next week. Bye-bye.